This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to provide you with an overview of pleural effusions.
Let's discuss pleural anatomy and physiology. The visceral pleura covers the entire surface of the lung, where the parietal pleura, which is a reflection of the visceral pleura at the apices and along the lateral edges, covers the inside of the chest wall, the mediastinum, and the diaphragm. Intrapleural pressure is approximately -4 to -5 centimeters of water. The pressure is caused by a balance of forces. First of all, lungs have inward retractile elastic forces, while the chest wall would naturally enlarge with the lung removed and is pulling outward. Negative pressure in the pleural cavity may help prevent atelectasis along with surfactant, which decreases surface tension in the lung. We have about 20 cc's of pleural fluid in each pleural cavity on average. The parietal pleura is responsible for formation and removal of new pleural fluid. Formation of fluid is related to a balance of Starling's forces. Flux, or Q, is the product of the permeability times the pressure gradient across the pleural surface minus the oncotic gradient. So what we're trying to say is the higher the microvascular pressure relative to the perimicrovascular pressure, the more fluid is pushed into the pleural space. That's flow or flux. Permeability is the relationship of how much is moving at a given pressure gradient. So a high permeability or an elevated K means the lungs are very permeable. They act like a spaghetti strainer, and more fluid moves into the pleural space at the same pressure. In the opposite direction, which is a minus side, opposing the pressure is oncotic forces. So the oncotic pressure inside the microvascular space holds fluid in the microvascular space, and that measure is relative to outside or the perimicrovascular space. So we know that high protein stores in the blood keep fluid in the blood, and hypoalbuminemia actually encourages fluid to move outside the vascular space and causes peripheral edema, such as seen in malnutrition states like kwashiorkor or low albumin states in critical illness. So we know that the overall formula is that the movement of fluid into the pleural or any space outside the vascular space, which we call flux, is the product of the permeability times the difference between the hydrostatic gradient minus the oncotic gradient. So every day the pleural fluid is refreshed, and the parietal lymphatics can keep up with a 20-fold increase in pleural fluid production. So if there's more fluid added to the pleural space, we can keep up with that by having more lymphatic drainages, provided it doesn't go much above 400 cc's a day. Now, when we start to accumulate more than 400 cc's of fluid a day and our lymphatics can't keep up, that's when we start to accumulate pleural effusions. So pleural effusions only occur if we overwhelm production or we're unable to drain the fluid that's accumulating by lymphatics, or a combination of both increased fluid production and decreased lymphatic drainage. So let's continue our discussion with a review of the anatomy and physiology of normal pleural fluid production to allow us to better understand where things could go wrong. As I mentioned earlier, the pleural cavity is a potential space, pictured here in blue, sandwiched between the visceral and pleural surfaces. On the lung side of the pleura, shown on the left, surrounding the alveolus and pulmonary capillaries, is the lung interstitium, which is shown in red. On the chest wall and rib side of the pleura, shown here on the right, surrounding the systemic capillaries is the parietal interstitium, shown in yellow. The pleural epithelial surfaces comprise the parietal pleura on the chest wall side and visceral pleura on the lung side, shown here in green. These cells are supported by the basal lamina, shown in purple. As I mentioned earlier, the intrapleural hydrostatic pressure is about -5 due to the balance of inward retractile forces of the elastic lung tissue pulling inward and the outward retractile forces of the chest wall, which tend to expand outward. The systemic capillary system in the parietal pleura maintains a higher pressure than the pulmonary capillary pressure in the lung interstitium, creating a hydrostatic pressure in the parietal space of approximately 30 centimeters of water and a hydrostatic pressure in the lung interstitial space of approximately 25 centimeters of water. This creates a gradient of 35 centimeters of water from the parietal interstitium relative to the pleural space, while the gradient from the lung interstitium relative to the pleural space is modestly lower at 29 centimeters of water. Due to the differences in these two gradients, a net gradient of 6 centimeters of waters favors hydrostatic flux of fluid from the parietal pleura to the pleural space. Net movement of fluid from the parietal space to the pleural space not only depends on the hydrostatic gradient, but also depends on the permeability per Starling's equation, which I just went over and is shown here in a simplified format. This equation once again shows that the flow is not only proportionate to the net hydrostatic force, such that if the hydrostatic force would suddenly triple due to heart failure, the flow would also triple, but also proportionate to the membrane permeability. That is reflected by the K in this equation, which is the permeability factor. Normally, the junctions between the pleural lining epithelial cells are tight, making the permeability, or K, a low value. However, with pleural inflammation, the junctions become leaky, thus K increases with increasing flow at any given pressure. Of course, if fluid only flowed into the pleural space and had no way out, we would all be suffering with very large pleural effusions. Fortunately, the lungs are equipped with a rich network of lymphatics on the parietal surface of the lung that collects fluid through tiny stoma and returns the cycling fluid to the systemic circulation via the thoracic lymphatic collecting system. Pleural effusions only occur, as I mentioned in the prior slides, if the rate of flow into the pleural space is markedly elevated through Starling's forces, or there is some sort of obstruction of lymphatic flow going out of the pleural space. So I want to discuss the role of ultrasound in pleural effusions. When we use ultrasound to guide thoracentesis, we have a higher rate of successful aspiration. We have more accurate quantification of the amount of fluid than a chest x-ray. We can visualize septations better than a CT. There's a decreased complication rate. And it's also useful post-procedure to rule out a pneumothorax. We use lung sliding as a sign to prove there was no pneumothorax. I'll show you how that goes in just a minute. And there are other uses, like ultrasound can demonstrate well-aerated lung or consolidation. So here's a thoracic ultrasound I performed in November of 2018 on a patient with an effusion. So the probe is put up the skin, and this is a phase array probe, so it's spreading outward from the probe in a triangular configuration. The head is on the left of the screen as you face the screen, and the feet are on the right. So the chest wall is close to the probe. The diaphragm is that little white line at the tip of the arrow. Towards the feet is the liver. That little triangular area is the tip of the lung that's atelectatic and compressed by the fluid. And the effusion is echo-free, homogeneous black because it transmits the ultrasound very nicely. Water is a very good ultrasound transmitter.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.